Today we'll be discussing the ultrasound foraminal technique, a new technique, just pointing on the safety and the accuracy of this technique. So first, if looking into the literature, you can see that already the ultrasound, starting 2005, is a validated technique in the transforaminal steroid injection. And you find many articles comparing it to fluoroscopy and to CT scan. It has a lot of advantages, but still needs a lot of improvement because it has some pitfalls. So if we, always you see that it is not inferior to the fluoroscopy. It's still a technique. The fluoroscopy is still the most commonly used technique and the gold standard technique. The ultrasound is sometimes as efficient in the literature, sometimes it's not as efficient. Mostly, whenever you reach the foramen, you have some bony structures and you're not being able to visualize the tip of your needle. So there you might puncture a vessel, you might injure the nerve, and you have no idea about the diffusion of the big picture you're putting in the foramen. So this is Dr. Masoud Hashimi, who did a paper about comparing fluoroscopy and the ultrasound, and he found that ultrasound is efficient in 90% compared to fluoroscopy. Also, this is another paper where they compared the transforaminal epidural injection to fluoroscopy-controlled injections, and they found that it is like 85% as efficient. This is a German paper where they compared MRI, CT, and ultrasound in surgical nerve root injection infiltration. The most accurate definitely was the MRI, then the CT guided. The pitfalls of the CT was like the radiation, still you have radiation. The MRI was like double the price of the CT. Definitely, the ultrasound was the cheapest technique to do the transforaminal steroid injection, but it was not that efficient compared to MRI and to CT guided technique. So this is a paper by Dr. Samer Garouz, where he did some ultrasound surgical selective nerve root clogs, and he validated this injection with the fluoroscopy, and he found that his needle was like at 5 millimeters most of the time from the targeted area. So it was, ultrasound was not that accurate. It was not as accurate as the fluoroscopy for him. And he concluded that a randomized controlled trial to compare the effectiveness and safety of ultrasound imaging against other imaging techniques seems warranted. So we're still lagging safety, accuracy with the ultrasound. This is another paper in the back, ultrasound versus fluoroscopy, and they concluded that fluoroscopy guidance of injection for the management of lower back pain is similar in efficiency. So ultrasound and the fluoro are as efficient as technique, but the exact role of ultrasound guidance need to be further studies, especially for nerve root injection, where safety is the major concern. Once we bypass the intertransverse ligament, safety is the main issue with the ultrasound guided technique. You can find more and more publications trying to improve the visualization at the tip of the needle. So they used combined ultrasound with fluoroscopy, ultrasound with stimulated guided technique, another technique with MRI, image diffusion guidance, and sometimes some bubble tip at the tip of the needle, trying to improve the visualization and the localization of the tip of the needle. Here, you are losing the main advantage of the ultrasound. It's not anymore a bedside technique or an out-of-hospital technique. You need in-hospital machines like CT, MRI, fluoroscopy to confirm the right position of the tip of the needle whenever you're doing an ultrasound-guided technique. The most common nowadays is the combining fluoroscopy to ultrasound, helping the ultrasound with fluoroscopy, either checking the diffusion of dye inside the foramen, checking for vascular injection, or using the ultrasound like here in this publication, just to localize the foramen, then to decrease the time of radiation, ionized radiation, using the ultrasound to decrease the time of ionized radiation. But still, as you can see, there's no main advantages. We're losing the advantages of the ultrasound. So this is a narrative review. We know that the ultrasound transforaminal technique has been described in 2005. Just we have a few publications about the subject, and all of them concluded that still we need the best approach to the ultrasound transforaminal is to use the fluoroscopy as a help to check for the for intravascular injection for epidural steroid diffusion. We describe a new device, the EvoTouch, which combines the ultrasound to a scope, to intraneedle scope. This is a solo device where you can do the transforaminal steroid injection with one device. And it's very helpful, it's very accurate, and it's very safe. More safe than a fluoroscopy because you'll be able to see the nerve and you don't have any intraneural injections, the way you are blinded in fluoroscopy. So in this device, you have only one screen where you can put your ultrasound and the scope inside the needle view on just one screen. So the needle, like an introducer with a multi-port cannula at the other end with a unidirectional valve, while the scope will go inside the needle, and you will have an excellent view at the tip of your needle. So this is the introducer, which is going to be guided under ultrasound guidance. You're going to see all the vessels. It's going to be a real-time guidance to the foramen, to the lamina. Once you're at the lamina, at the intertransverse ligament, you're going to put your scope inside the introducer and to check the view just at the tip of your needle, checking for vessels, checking for nerves. So you need the help of an assistant here, where you're going to put, usually what I do put a 5 cc normal saline, just put a little bit of pressure in the other port, and you can inject your steroids, your mixture, through this port. So, with no further delay, I'm gonna, what was the rationale about this technique? Why did we develop this technique? We developed this technique to just have the benefits of ultrasound. The benefits of ultrasound are real-time guidance. You can see the soft tissue, you can see the vessel. You're not puncturing any vessel outside the foramen, mostly in the cervical area where there's a lot of vessel, a lot of soft tissue structure. You're avoiding all those structures. It's still a portable device. It can be done in the European clinic. You don't need to go to the OR or to the radiology suite. You don't need ultrasound, MRI, big devices. Definitely it's a lower cost. You don't need a fluoroscopy, a CT scan to check on it. Definitely, as you saw in the German study, it's a lower cost compared to other techniques, and definitely it has no harmful ionized radiation. No CT, no fluoroscopy, no radiation. So the advantages of the microendoscope was to increase the success rate. You're 100% sure that you're in the foramen. Once you see the artery and the nerve, you're sure that you're in the foramen. And you don't need the fluoroscopy guidance. Added to the advantages of ultrasound, you're not going to injure any nerve. The fluoroscopy technique, you're going blindly inside the foramen, and you might injure or inject next to a squeezed or to a compressed nerve. Also, to decrease the risk of anaphylaxis with dye. Most of you have some patients having allergy to dye, or having a pregnant lady where you cannot use a fluoroscopy, okay? Or you're having a pediatric patient. So you don't want to use that. You cannot use the fluoroscopy. So this is the best technique in this way to do your foraminal injections. And definitely to minimize nerve injuries and vascular puncture. That was the rationale about it. So how do we do it? We still do the Galliano technique, which was like described a few years ago. We start scanning to the level we do want. Once we have the level, We look for the transverse process, start scanning down to see the laminar view, and take the tightest area in the laminar view. Usually to do this technique, it's better to turn your probe a little bit down, having a small angle to open the foramen and be perpendicular to the lamina. So this is what you're going to see on your screen. First, we're going to see the sacrum, then we see L5S1, then L4. We start localizing the level we need to inject. Once we have the level we need to inject, we turn our probe to a 90-degree angle, and you're going to see here, still, this is the interlaminar view. Those are the transverse process, the facet, the spinous process. You start scanning down a little bit to have the laminar view. This is the laminar view, this is the lamina, okay? And this is the spinous process. This is the foramen right here, and this is the vertebral body. We inject, we take like 1 or 2 centimeters away from our probe. We do inject in plane short axis. With our needle, you see the needle, we just stop at the tip of the lamina. Once we are at the tip of the lamina, usually we are at the intertransverse ligament. This is where we do put our scope inside. We just move our screen to have the ultrasound right here and the scope right here. This is the intertransverse ligament, and we're passing through with our needle. So we do put our scope inside the needle, and we keep like 2 to 3 millimeters away from the tip. We need our needle to dissect for us. And our assistant is having a syringe with normal saline, putting a little bit of pressure just to take the tissue out, just for visualization, not injecting normal saline. This is where you're gonna see anyone in the foramen. This is the artery, this is the vein, and this is the nerve. You see the vessels is just above the you see the pulsating artery, and the nerve is right here underneath the artery. With your needle, with your bevel of the needle, you can turn the needle right and left and have a 360-degree view inside the foramen. I'm not doing surgery, so whenever I'm like seeing the artery, I'm stopping there. I don't need more than this. Usually you don't see the artery sometimes, but you see the pulsation. Also, you can stop there, because you need you're just putting some steroids, and it's going to diffuse in the epidural space, as we're going to see in a while. Okay? So this is the foramen, the artery pulsating above the nerve. So in those cases we've checked with fluoroscopy to make sure that whenever you see this artery and you inject, your product will go inside the epidural space. And this is what happened. Once we saw the artery, we inject 1 or 2 cc of that, and it went all around the nerve in a sleeve diffusion, and in the epidural space. You can see it, it's not that clear on the lateral view. So this is the AP view, and this is the lateral view. So we did until now 7 uncomplicated cases, which has been followed for 6 weeks. It was very efficient as X-ray guided. It is very safe. We saw the diffusion going inside the epidural space. So, and we concluded that whenever you see the artery or the nerve and you inject your product, it's going to diffuse in the epidural space. Ipso facto, because you are already inside the foramen. You bypass the intertransverse. So the advantages of this technique, it is as successful as fluoroscopy, and we're hoping that it's going to be safer than fluoroscopy, because you're going to prevent intraneural, not only intravascular injections. We decrease definitely the radiation. We have multitude of indication. Whenever you have anaphylaxis to dye, allergy to dye, pregnant ladies, you cannot do fluoroscopy, you cannot inject dye. This is the technique to go. You don't need the X-ray guidance. You don't need hospital-based equipment. You can do it in the clinic on outside basis, and definitely it will have a lower cost no nerve injury, no vascular puncture. Definitely you have a decreased time, and it has been proven by most of the study. If you do it in ultrasound, you don't need to direct a lot your needle. You have less attempt, less redirection, because you're seeing you're having a real-time needling under view by the ultrasound. So we need to expand its application. In the future, we're hoping to grade the stenosis of the foramen, because we're seeing the foramen. We can grade the stenosis of the foramen and correlate this foraminal stenosis to the outcome of the patient, saying that if it's so and so stenotic, the patient will improve that much. We need to correlate the stenosis to the outcome of the patient, or directly saying that this is a very tight, it's not going to improve, there's a fragment there, we need to do a surgical approach, there's no way to do a foraminal approach for this. So we have future plan to grade the stenosis inside the foramen and to put some indication and correlate it to the outcomes of the patients. Other plans also is to do it, to use it in the cervical area where an intravascular or intramedullary injection is catastrophic, and where everybody stopped, they need the fluoroscopy as a guidance. We think we can do it without fluoroscopy in a very safe way, seeing the nerve and seeing the organ. Also, we can use the ultrasound-guided neuromodulation or rhizotomy, seeing the posterior ganglion. We can approach the posterior ganglion also by this technique in the future. Thank you very much. Any questions?
Thank you very much, Dr. Rizk. I think it's most impressive and great advance in technology to make the procedure safer and all the reasons you mentioned, better outcomes perhaps. But I think there is no doctor here in the audience that does not want to see what is at the end of his needle. And of course you showed us some interesting news about further, let's say, research, what you are going to do in the case of grading, compression, of course advanced procedures, ganglion ablation, using laser for things like that. I'd like to know if someone in the audience like to ask Dr. Rizk something about this technique.
Thank you, Dr. Rizk, for the presentation. It's really impressive. I just ask, like, what is the reason, how you can explain not to visualize the lateral view compared to the AP view in contrast to confirm the placement of the needle?
No, that was a bad picture taken. That was a bad assistant. I was sorry about the lateral view because the assistant didn't focus before taking the picture. But if you want to see it, it's just in the right spot.
I see.
Yeah.
Because lateral matters also for the depth of the needle. We need to know like how deep we are from the lateral view.
Yeah. Yes, definitely you need, but it was just at the tip of the foramen. It was there for sure. And in the AP view, you can assess how much it's going inside the foramen. The good thing that you are seeing the nerve and the artery. You don't look for how much you're going in anymore, because you're just seeing inside the foramen. Okay? Thank you.
Is there any other question? Yes? Introduction at the end. Can you bring it? Yes. Sorry, was one. Oh.
It was a very fascinating talk. I thought one of the advantages was that you don't need fluoroscopy or you don't need dye, but in your case you you said you still use fluoroscopy and you injected dye to confirm the position and the spread?
Usually we're not using fluoroscopy. I did it just علم للعلم. I just did it for scientific purposes, just to prove that whenever you see the artery, you're inside the foramen.
Okay.
Just to prove it, I did the fluoroscopy.
Okay.
Usually you don't need the fluoroscopy. Once you see the artery, you're done. But it's just to tell you that once you see the artery, diffusion inside the foramen and in the epidural space is there. It's going to happen.
Okay. Thank you so much.
Thank you.
Thank you very much.
Thank you.
Yeah, about the presentation and your innovation. But do you have any study comparing the what's called safety and accessibility for this technique against the conventional technique? Thank you.
Okay. We're still doing the studies. We're having a big study in the IRB to control. Definitely we've done until now 7 cases. Definitely we need a bigger number to check. My impression, the way I'm doing the technique, for now I had no complication. It was as efficient as the fluoroscopy. This device has passed all the safety devices in Europe, and now it's going, the papers are in the United States to have the safety for this device as a device safety, I mean. As I told you, ultrasound technique is already validated. We do ultrasound foraminal injection. The only thing, once you are at the intertransverse ligament, you don't see what's going to happen. With this, you see. So definitely we have more safety because we're going to see the artery and the nerve. In fluoroscopy, we do inject dye and we're sure we're not intravascular, but we know nothing about the nerve. Sometimes the nerve is squeezed, and any volume you were going to put there, it's going to compress more on the nerves. So you're not safe nerve-wise. With this, you can just visualize the opening, visualize the stenosis, and be sure that what you're injecting is not going to compromise the safety of the nerve. So I don't have yet any published safety for this device. Hopefully soon we'll have a lot of publications and things like that.
Hi, this is Dr. Shravan. I've just came to Dubai here. For the last couple of months, I've noticed so many fusions in the back that I've done in the last 5-6 years as a pain consultant. I just want your input. Quite a very good innovative techniques you have. What will be your input if somebody had a metal work done? Would you change your technique or?
Sorry, having what? Sorry, I didn't hear you. Having what?
If somebody has a metal work inside, would you change any of your technique or what would be your approach?
Someone has a metal implant.
Ah,
Someone has a metal implant, would you change the way you do things?
Okay. Implant, you mean? A narrow implant? Hardware. Yeah. You know, whenever you have hardware, you know, the foramen will not be visualized adequately. Whenever I used to do the fluoro technique with the hardware, I used to just compare both sides just to estimate where is the foramen and to go by a paramedian approach. This is the paramedian approach. This is not like doing an oblique and going inside the foramen. This is exactly a paramedian approach. Definitely with hardware, we're worried about the visualization of the foramen. I think it's going to be, we didn't do it yet, I think it's going to be difficult to visualize under the rods the foramen. So maybe I would stick to the fluoroscopy with a paramedian approach, doing a sleeve approach from the paramedian with hardware. To be as far as possible underneath the hardware, not touching the hardware for infection problems, and to be able to reach the foramen. I don't do it under fluoroscopy yet, under ultrasound, excuse me yet, but we need to explore it, but I think it's going to be difficult to reach the foramen whenever you have rods.
Excuse me, Professor? No. I have actually done once case with the hardware.
Okay.
With
Under ultrasound guidance?
Under the ultrasound and with this the Endoscopic.
Okay.
And just one case, and sorry to tell, but actually, I believe that this kind of procedure is even better when you have the rods and the screws and everything there. Because actually, when you have the hardware, it's more difficult to see, even in the X-ray, sometimes you have difficult to put your needle, and with the ultrasound it's impossible. So when you have this kind of device with the camera, and you can have the image, the direct image of what you are doing, is quite good. I could reach the foramen with easier than using the X-ray when you have the screws and the hardware there, using the Endoscopic.
The issue is you don't have laminas. Usually when you put screws, you use your laminas.
Sometimes, yeah.
Yeah, so it's difficult to see the lamina and to go toward the lamina. This is what, I don't have the experience, I've never tried it, but just like thinking about it, that, I don't know, but this is still like the paramedian approach, the one we use it with the fluoroscopy whenever you have roads. So this is almost the same approach. So yeah, it should work at one point, but I don't know if you don't see the lamina, what would be your leg one? Maybe the vertebral body go down and just estimating that the foramen is just above the vertebral body. Maybe looking with the ultrasound to the vertebral body, okay, and just injecting above the vertebral body. Might be an option to look after it, or just instead of doing a transverse view, have a parasagittal view. Maybe we can find a window through the parasagittal view to do this approach and to visualize the tip of the needle. I think the parasagittal approach would be better than a transverse approach for those special cases.
Yes, and you can see the rod
go. Just to go a little bit laterally from the road, divert your needle toward the vertebral body, and just go. Yeah, might work. I didn't try it, but one might work.
Thank you very much. Any other question? Dr. Rizk,
thank you.
Just a short final question. I'm using the same device as I showed you this morning for the quadotomy. Now, of course, I have not that experience for foraminal procedures, but I did a few in the direct vision because we all talk about high selective rhizotomy, etc., etc. And for me, it was always difficult to understand what is a high selective rhizotomy if you are not aware of approaching the dorsal ganglion. So I will try to search for it. Did you ever see in your experience the dorsal ganglion?
No, I've never seen it, but I think I'm very close. Very close to it, because I tried to dissect posterior to the artery and advance a little bit, and I think I need less than a millimeter to be, because when I checked it over the ultrasound, I was almost there at the just line of the facet joint. So I was almost there.
Yeah.
So I need to just we started with the foraminal steroid injection. Definitely future plans, we need to expand it to dorsal root ganglion rhizotomy. Definitely this is a must. We need less than a millimeter to be there.
Dr. Rizk, thanks again for your interesting...
Thank you, my pleasure. Thank you very much.